My name is Dr. Kevin Lutchman. I'm here to introduce Dr. Eirini Iliaki. It's my pleasure to introduce her. She's a board-certified infectious disease specialist at the Cambridge Health Alliance, and she's an instructor of medicine at Harvard Medical School. Her work bridges several important areas, including clinical infectious disease, occupational health and biosafety, travel and tropical medicine, tuberculosis, infection prevention, vaccine programs, and emerging infectious diseases. And it's truly my pleasure to introduce her, and we're very fortunate to have her share her insights on the herpes B virus and its intersection with occupational medicine. So without further ado, I will go ahead and allow you to take over, Dr. Iliaki.
Perfect. Thank you very much, Dr. Lutchman, for the invitation. It's a pleasure to work with you, and actually I will present a case that we saw together. Perfect. I have no conflicts of interest. So for today, by the end of the session, the hope is to conceptualize the reasons behind the current biosafety concerns for herpes B virus based on the pathophysiology of disease in macaques and humans, review the key aspects of B virus biosafety protocols, and identify post-exposure actions. So we will walk through the stages here, talking a little bit about herpes B virology and the host range, what happens in macaques, how from macaques we have the transmission to humans, and then what does that mean for humans, and then in terms of prevention, post-exposure, and a small summary. So true case, on a Friday evening, a young healthy scientist sustained a superficial laceration about 1 to 2 millimeters in depth on the left index finger. The scientist was using a scalpel to dissect non-human primate liver tissue from a thin section. The type of non-human primate was an imported cynomolgus macaque who tested negative for herpes B and SIV serology 6 months previously, and unclear time of sacrifice for the tissue harvesting. In terms of first aid, the scientist washed with soap and water immediately for about 5 minutes, rubbed the area with alcohol wipes. How would you quantify approximately the risk for herpes B virus acquisition? Would you consider this a high risk, a low risk, or zero risk? You can take one quick moment to think about it, and then we'll go on to talk about how to think about this.
See you later, Marie. Thank you.
So the virus species is called, changes names all the time, but right now it's called Macacine alpha herpes virus 1. And usually we use herpes B virus or B virus, and you see here the prior names. The genus is Simian simplex virus, and the family is basically Herpes viridae family. It's an enveloped DNA virus, and this type of virus does not exist in humans, but it is similar to our human simplex virus 1, HSV1. So the host range is monkeys of the genus Macaca, which the old world. And you see the different types there. In the dark areas, the black-gray areas in the map below is where the macaque range is, and it's basically in Asia. There's been an increase year by year in the use of macaques for research due to the homology with humans. And with data from the US Department of Agriculture from the 2024, there are about 100,000 non-human primates either that were used or still in research laboratories awaiting for use. So large number. What happens in macaques? The infection resembles the human herpes simplex virus infection. So mostly it's an asymptomatic carriage. Almost all of the populations of macaques are seropositive. There is occasional shedding, and the shedding can usually occurs under stress, but it can be asymptomatic shedding, or it could manifest with the development of vesicles, which are similar to cold sores in humans, like you can see on the picture to the right. Non-human primate materials are obtained from animals that have tested antibody seronegative for B virus, but animals with no detectable antibody should be presumed infected with herpes B virus. And why is this? Number one, because they could be infected and shedding, but the antibody might have not turned positive yet. It takes about 2 weeks or 4 weeks to turn antibody positive. Also, it's a very difficult assay, so there could be a false negative as well. Also, the antibody testing happens at one point in the life of the macaque, and this could be weeks or months before the organ or tissue harvesting. So it is not done the day that the macaque is sacrificed. And around the time of sacrifice is the biggest stress, even though, of course, there are protocols to prevent it. How does the transmission happen? Skin, percutaneous, and mucous membranes via direct contact. That's the by far the most common. That's the bulk of the transmission. So through the skin, contact of the researchers, non-intact skin with the virus, either directly in contact with infectious tissues or fluids of monkeys, or via fomite, for example, if it can survive in surfaces, and if there is an opening on the skin, and then we touch that surface where the fomate is located, that's again direct contact. Mucous membrane, through mucous membranes, especially the eye, there have been several published reports. So that's direct contact with a virus through a splash, or again, let's say that the scientist touches an infected area and then rubs their eye. Through the area, there is a questionable case 50 years ago, but it's unlike based on other exposures. And again, these are theoretical, but it's not clearly documented. And also these are the basic modes, percutaneous and through mucous membranes with direct contact is also how HSV is transmitted. And talking about transmission and exposures, this is a review of the first 26 cases. And on the right side, you see how many cases were from each type of transmission. And you'll see that the bulk of transmission happens to people who handle animals or their cages directly. And it's more rare to have the exposure through, for example, a tissue culture bottle cut that you see there. And you'll see there where it says human to human contact. And as I said, this is not a standard transmission method. What happened in this case was a scientist got vesicles from contracting herpes B in their lab. He was diagnosed with some type of dermatitis, and his wife was applying hydrocortisone on his lesions, and it is presumed that she had some cuts or eczema, and that's how. So basically, it's like touching the skin with touching the fluid. So direct contact, instead of touching a surface, it was the probably direct exposure with a hand. You might recognize Beth Griffin's there. Unfortunately, she's the last victim in the US in 1997. There's a foundation in her memory and efforts to prevent these unnecessary losses. So quick summary so far, only macaque species, asymptomatic infection in macaques, and all are considered potentially infected despite negative herpes B serology provided by the vendors. Main route of transmission to humans, percutaneous through mucous membrane, highest risk in people who handle macaques, and the risk is low, not zero, in laboratory workers who work with NHP tissues, cells, and fluids. What happens in humans? So if you look to the right on the screen, if let's say the injury happens where the red arrow is at the skin surface, and let's say there is an infected scalpel with the virus, what happens first is the virus enters the skin and starts replicating on the site within 5 minutes. This is why you will hear within 5 minutes a lot in this presentation. Viral spread then happens through the peripheral nervous system, neurotropic virus, so that's what it likes to replicate, and gradually moves up into the dorsal root ganglion and through that into the spinal cord, and then proximately goes proximally to the brain. The incubation is about 2 to 5 days, and we will talk more about the mortality. So on the right-hand side, basically the symptoms sort of mirror this pathophysiology. So early symptoms might be pain, numbness, or tingling at the site of infection. There might be vesicles at the site. And then there is fever, headache, muscle aches, fatigue as the body is starting to respond. And then later symptoms, about a week to 3 weeks later, are the neurological symptoms, such as encephalitis, seizures, confusion, coma, respiratory failure, which usually leads to death or ascending paralysis. A question we get asked is, can herpes B establish latency after acute untreated infection if survived? And, you know, there's so few cases to begin with in the literature. So amongst everything that's published, which is about 50 cases, there is one case report of reactivation 54 years after the primary meningoencephalitis. This happened in Belgium, where apparently they keep very good medical records, because a 66-year-old, healthy otherwise female, who had history though of lymphocytic meningitis 54 years prior, with medical information retrieved from the original medical files in 1965 that indicated in the history that the patient had had a monkey bite from a monkey that was gifted, and that preceded the meningitis episode, and the monkey purchased from a pet shop died a few days after biting the patient. Now, I remember I told you that in macaques, the infection is asymptomatic and it doesn't kill macaques. So why would this monkey die? Most likely because it was not a macaque, but when, although very unusual, but especially years ago, 50 years ago or more, the different types of monkeys used to cohabitate when they were transferred from Asia here. So it's quite likely that this was a non-macaque monkey who can catch it and then can be deadly for that species. So a rare instance. So now, 54 years later, at that time, of course, they didn't test for herpes B. But now, 54 years later, she presents with severe meningoencephalitis. And since they found this record, they tested for herpes B and they confirmed it with PCR. So raised concern for late reactivation of herpes B in somebody who probably got it and was untreated. Can herpes B infection in humans happen asymptomatically and then reactivate? So presumed latent infection that reactivated. I think that would be extremely unlikely. There is a case report that says maybe, but I'll tell you why I don't think so. So there's a case report from 1970s of a 61-year-old virologist who presented with ophthalmic zoster-like rash, and the illness progressed to encephalomyelitis. Skin scrapings were PCR positive for B virus. But although working in the lab, he said that the last contact with macaques was about 10 years prior, and he could not recall a clear exposure or illness. But non-human primate materials were present at the space of his work a few days prior to the presentation. But he states that he didn't handle them. But I think knowing that it's such a lethal virus and very vocal virus for humans, I wonder if really he touched the surface, maybe not directly in contact with the materials, but perhaps an area that was infected or soiled with the virus, and then perhaps he scratched his eye and got it that way. I think that's possible. There's no other, and again, as you might imagine, as I said, at least in the United States, there's 100,000 macaques, and there hasn't been, as you might imagine, there are many contacts and potential exposures, but there hasn't been another potentially asymptomatic carriage and reactivation. So I really don't think that is true. And then there's an obscure paper from Japan where they said that because they didn't want to reveal much to protect the company where those employees were working. So it's a very vague report where they talk about two macaque handlers from Japan with a chronic and long-term neurologic disease who at some point had studies that found that there was herpes B virus, but they don't tell us what this long neurologic disease is. So it's published in the Emerging Infectious Diseases, which is from the US. So I thought it's good information, but it's hard to know what to make of it because there's so much information missing. And I wouldn't assume that there is chronic infection based on this. We need more to understand a bit better what was going on in this case. So in summary, it takes about 5 minutes for the virus to enter the cells at the site of injury and about 2 to 5 days to enter the brain. Can cause vesicles in the beginning, sustained flu-like symptoms with fevers and fatigue, and ultimately neurologic symptoms at the time of neuroinvasion. Again, about 50 cases described, very, very high mortality. If it happens through the eye or mucosa, the first symptoms might be ophthalmic with conjunctivitis, uveitis, retinitis. That's actually what happened to Beth. It's very unlikely that there is asymptomatic infection with latency. And it is possible that one can have reactivation after untreated primary infection, but you might imagine that's a big deal. And in these cases, most people go into secondary prophylaxis for life. So prevention through education, training, mitigation is basically the most important thing that we can do. It's difficult because these are extremely rare to have effective transmission. But then if it happens, the mortality is very, very, very big. So the more we can do with training of researchers, especially macaque handlers, on risk mitigation, appropriate PPE, and SHARPs, yearly education, simulation of exposure response with scenarios for percutaneous or mucous membrane cleansing within 5 minutes from exposure. Because remember, we talked about the fact that if you wash off the virus these first 5 minutes, actually you are, it's highly likely there is not going to be further transmission. Easy to find a non-human primate kit that includes documents with who to notify. If need for AD, they can bring the document indicating work with non-human primates and what needs to be done after the exposure. We have protocols here about what needs to be done in occupational health, and or if it has to be an ED visit, what the person needs to bring with them. And there's also a 24/7 expert telephone line, the Herpes B National Center. Timely post-exposure prophylaxis prescription plan, and the sooner is the better. Within 24 hours is preferable and no later than 5 days. In terms of the risk levels where research is happening, BSL-2 is necessary for non-human primate materials, BSL-3 for diagnostic samples potentially containing B virus, and then BSL-4 for viral propagation. So back to the case, I can tell you, I know I asked you if the probability was high, low, or zero, and what were your thoughts about it? And I will tell you that the way I thought about it was that I would say the probability is low, but not zero. So the next question is, if you got that call at that moment, would you offer PEP and then refer for baseline and convalescent herpes B titers to the National Herpes B Center? Would you not offer PEP and not send titers? Would you offer PEP but send titers for baseline and convalescent titers for herpes B? Or would you call the National Herpes B line? And the numbers are on their website. I have them here. And I also added, if no response, I will page infectious diseases in one of the tertiary hospitals of my area. So if you want to think about it, and you could write some thoughts in the chat box. And Dr. Latchman, I think you, I don't want to change my screen to get access to it, but at the end we can comment. But if you want to take a moment. So 34-year-old scientist, previously healthy, superficial laceration, non-human primate liver tissue, cynomolgus macaque, per the manufacturer, negative, and did go immediately to wash for 5 minutes. Okay, so to help us decide, this paper has a checklist that can be helpful, but it's not always, you can't always find the checkbox to check off. And so I would recommend, I know that a lot of people use it. I prefer going straight to the CDC guidelines. So the recommendation for PEP depends on the type and timing of first aid, the type of exposure, the depth, the body part, source of macaque, the source macaque risk factors. And basically, if the answer to any of the questions is yes, then PEP is definitely highly recommended. And these are if the cleansing was inadequate, meaning if there was broken skin or mucosal exposure, and the person did not wash within 5 minutes from injury for more than 15 minutes. So if you remember this case, she washed within 5 minutes, but for less than 15 minutes. So this is not considered adequate cleansing to kill the virus. If the laceration is on the head, neck, or torso, this is considered very, very, very high risk because it's the proximity to the brain. If the puncture is deep, if it's needle stick associated with tissue or fluid from the nervous system, eyelid, or mucosa of the macaque, if the puncture or laceration with objects that are contaminated either with fluid from monkey oral or genital lesions or with nervous system tissues or known to contain herpes B virus. Again, no vendor these days will say, I haven't checked, or, oh yeah, they have herpes B and I'm providing. So any yes to those questions, PEP is highly, highly recommended. The next two questions, if there's a break in the skin that has been adequately cleansed, but needle stick involved blood from an ill or immunocompromised macaque, yes or no, and puncture or laceration occurring after exposure to objects contaminated with any with body fluid, but that's not from a vesicle, or with infected cell culture. So basically that was her exposure. So we don't know that they're contaminated, so objects contaminated with body fluid or infected cell culture. So this is this potentially infected cell culture, because we cannot tell 100% that this tissue is not infected. So in these cases, the CDC says PEP can be considered, but in general, I would recommend it in these instances too, if the answer is yes. It's a risk-benefit discussion, and there's really very little downside to valacyclovir, which is the preferred post-exposure prophylaxis. So I would err on the side of caution. If in doubt, I would call Dr. Julia Hilliard. Her phone numbers are available. You might need to try her a few times, send some text, and eventually she will call back. And again, if I can't find anyone, I can reach out to tertiary hospitals in my area. And at the end of the day, because we have to act quickly, it's okay to start and then continue the outreach in the next few days. And if you get a consult with Dr. Hilliard and she says, you know what, you can stop, you stop. But it's just getting that first dose within a few hours, preferably within 24, no later than 5 days. So let's continue the case. So this is what I would do. I would offer PEP, and I would do baseline and convalescent titers through the Herpes B National Center. And let's see what happened to the case. Actually, the case it was the end of the day, late in the evening. So the scientist drove home and lives outside of the metropolitan area and went to, the town's hospital ED, and the wound was evaluated. Baseline labs were normal, including negative HIV and negative Hep C antibody, and was found to be immune to hepatitis B. But at the time of the ED visit, the providers were unsure about what is herpes B or what it means to work with non-human primates. And even though the researcher tried to explain, they They did not discuss prophylaxis. They did not discuss kind of follow-up, and they did not think of reaching out to an infectious diseases specialist. It's really difficult because emergency room physicians don't run into these cases, especially outside of our kind of Boston metropolitan area. So 10 days after the exposure, the scientist was referred to our clinic. The researcher is well, completely healed laceration. Would you now offer PEP? It's 10 days after her exposure. So would you offer PEP at this time and send titers, or would you not offer PEP and not send titers, or would you not offer PEP but send baseline? Now it's 10 days later, so it would be 10-day post-exposure titers and convalescent titers. Again, if in doubt, would you call Dr. Julia Hilliard? So if you want to take a moment and think about this, and you can enter your thoughts or questions in the chat and we will go over them. So a researcher who presents 10 days after possible exposure, low risk. So if we follow the CDC, right, she would fall in this category that says PEP. Well, she didn't wash more than 15 minutes, so she washed for 5 minutes. So she technically even qualifies for the sort of must. But we know it's not all or nothing. I mean, but then she also had a potential exposure because the liver tissue might be infected. Okay, so we'll discuss it later. So post-exposure management, we talked these 5 minutes, you're probably tired of hearing it, but soap and water is the simplest thing. Sure, one can use chlorhexidine or povidone iodine, but what's been found to happen in these cases, there is panic, and then the researcher tries to find this emergency kit and loses time from going to the sink and washing with soap and water. So it's totally acceptable to wash with soap and water. You know, you can apply povidone iodine or chlorhexidine afterwards, that's fine. But this initial wash is very important to happen very timely. And for the mucous membranes, saline or water irrigation for 15 minutes. Unfortunately, Beth, again, the researcher who died in 1997, had a splash of feces to her eye, kind of rubbed her eye, and then did not, unfortunately, irrigate until a few hours later. So missed that window. Additionally, unfortunately, she presented in the emergency room with eye symptoms, and also it took several days before the doctors realized that this could be herpes B. They only realized it when they saw the neurological symptoms. So in terms of, so one thing is the first aid, and then access valacyclovir quickly. That first dose, 1 gram every 8 hours for 14 days. And then according to the guidelines, blood work for herpes B serology is recommended to be done. A baseline test, and then repeat in 3 weeks. And I know this is very difficult, and colleagues from my area, Brandon Lins et al., wrote a paper recently, which I have in the references, where they basically said, you know, it takes weeks or months to get those results back. Does it even matter if we give post-exposure prophylaxis to have these serologies back? Also, there's none of the persons who died had gotten proper post-exposure prophylaxis, none. So the other argument is, if we give post-exposure prophylaxis, it sounds like we probably eliminate the possibility. So why keep checking serologies? But the guidelines that are from 2002, I think, they still say to do that. So we're expected to do that. And then you saw that in the case I presented the further information. So, you know, once, if it is macaque, and we know that macaques can have herpes B, it's enough to jumpstart this protocol that you see on the left. And then, and actually the blood work for herpes B serology doesn't have to happen that same moment. It can happen a day or 2 or 3 days later, that's fine. The most important thing is what's in red. Then we can obtain more information about the species, the exposure, the types of fluids. For example, the tissues that the researcher was working with, as I said, liver tissue, we asked, you know, was it frozen? Was it in formalin? Actually, she said that it was in formalin, but only for a few minutes, up to maximum half an hour. So it wouldn't be enough to fix and kill the herpes B virus. So, but if it was enough time in formalin, then we could have said, you know, no exposure. And don't forget to report to your local IBC, a local regulator. So in Cambridge, I'm part of the Cambridge Biosafety Committee, and we have this clause on our paperwork. So we welcome voluntary reporting. And Boston has a specific form they want people to fill out. So some key points from the presentation, and then we can go to the questions. So extremely rare infection in humans, less than 100 described, 80% fatal in humans. Exposure of macaque handlers have the higher risk, some risk with lab work, with tissues, fluids, blood. Highest risk is definitely brain, eye tissues, fluids, whether it's from a vesicle, urine, feces. Exposure, the bulk, is through percutaneous splash to eyes, nose, mouth, or non-intact skin. Preventive measures are paramount because it's the only way we can decrease the chance of exposure. Training, I highly recommend simulation, appropriate PPE and barrier protection, and then an early response to an exposure may prevent development of infection with wound mucosal cleansing, irrigation within 5 minutes of the exposure for 15 minutes, and initiation of antiviral pills. Valacyclovir is the most preferred regimen, 1 gram every 8 hours for 2 weeks. And then serologies to the National Herpes Center. I have some additional references, and a lot of my references are in the slides. And we have plenty of time for questions. So I'm not sure how to, Dr. Latchman, if you can.
Yep, I think our guests can unmute themselves, and they should be able to ask questions if they'd like.
I have a question. Hi, everyone.
Hi.
My name is Candace Tanis. I'm an occupational medicine physician at the Salakoff Centers at Mount Sinai in New York. And I just have one question about just going back to, when to start the post-exposure prophylaxis. I don't recall, I'm sorry if I missed what the decision was, if someone comes to you like 10 days later or what have you, but is there a downside to, even if they are technically outside of that window for the, and initiation of that first dose, is there an argument to be made to give them the treatment? And the reason why I say that is that what happens in our clinic with our needle stick or those types of similar injuries is they come in, they go to the emergency room, and then they get referred at Mount Sinai, and then they get referred to our clinic, and we do our best to get them in within a couple days, but usually there's like a week lag time. And RED is usually, when it comes to bloodborne pathogens like, HIV, Hep B, Hep C, etc., RED is usually on top of, starting them on the medications, drawing the initial lines. But what about for this?
Yes, very good point. And so I was going to see if there were other colleagues that would like to comment what they would do if they were 10 days later. So I think you can offer, and we did discuss and offer, but it doesn't make a lot of sense, because by that time you would have established latency. Let's say that she was one of these cases where she was asymptomatic. It was 10 days later. We know the incubation is around that time. Usually by the first week you have a symptom, something, and she had nothing. So, and then ultimately I did call Dr. Hilliard because I wanted to understand better whether I should push for her to get it, even though it was 10 days later. And again, understand a little bit better the risk benefit. So as you might understand, it's a difficult decision at the time. And what we discussed was that, we offered, she didn't want it, which was fine, again, because, again, the benefit would be probably close to zero at that point. And then we went for very, very close monitoring for symptoms with an expectant plan. So we wrote a letter that she would bring to the emergency room at any time of the day or night. She had a fever or a rash at the site, and for the discrete details in the emergency room that they need to call infectious diseases and basically just start IV acyclovir. So that's one thing. The other thing that we discussed with Dr. Hilliard is that if she got valacyclovir, we would not know if she really got infected. I mean, the serology is a terrible test to begin with in humans, because we have background antibodies from HSV, and because there's 50% homology, the HSV antibodies that we have look a lot like the herpes B antibodies. So the test is really difficult to perform. And if she got valacyclovir, we could have muted that response. And so she would never know if she was one of these rare, I don't know, asymptomatic, or maybe the first asymptomatic carrier. So she pointed out, you know what, maybe it's not the end of the world anyways, because then at least we have pure serologies that we can follow. We could do the 10-day serology, probably early to see anything. So it could be the baseline serology. And then what we did is in close follow-up, and we brought her back at multiple time points. We brought her back at 3 weeks, 6 weeks, 3 months, and 6 months, actually. And all these serologies were negative. What I would say, and I've heard from other colleagues the struggle that you describe to get the valacyclovir quickly. I've also heard people getting it, but not on the right dose, because this dose of 1 gram 3 times daily is very specific for herpes B virus. Everything else we treat in humans is at most 1 gram BID, so that's another limitation. We hear people who get the script and then they go to the pharmacy, and the pharmacy asks for a lot of money because they say, oh, it's not covered by your insurance, whatnot, and then the patient decides, okay, well, I guess I'll wait, and on Monday I'll get in touch again with my doctor. So we hear a lot of that. So to circumvent it, we're trying to be creative. One item that we discuss with our clients, whether it's universities or companies, is, can you have valacyclovir at the site with a prescription, so pre-fill it and have it at the site. So after the first aid is done, then you go to that first aid kit or bite kit or non-human primate kit, and then you open it. And in the instructions, it says, and open this box and take the first dose of valacyclovir. So that's one option. A lot of technicalities there with the prescription and so on, but there are workarounds. So it's one option. Other option is to, if you're close, to have details for the emergency room. I can share what we are using. We're using something very simple, basically. And in those details as well, we say, basically, we make it very simple, and we say, well, please give 1 dose of valacyclovir orally, and prescribe it for 14 days. With our emergency room, where we, at least our clients, we encourage them to go to our emergency room, and there we have a 3-day supply. The same way we have a 3-day supply for HIV PEP, we have a 3-day supply for this purpose. So another idea to think about to get to it quickly. Other questions or thoughts? How does that sound useful for you?
I don't know.
Thank you.
Perfect. We do have a couple of questions that hopefully we can get to from the comments. So our first question, we have, let's see, one from Susan, and she asked, does the expert, and to which I believe she's referencing Dr. Hilliard, work for the federal government? And if so, are they still functioning?
They were before the shutdown. They were before the shutdown, yes. Yes.
And then Jennifer asked, go ahead.
Sorry, Dr. Hilliard actually works for universities, so she doesn't work directly with the government. On the CDC website, you will see Dr. Cohen's information, who works for the CDC. And I haven't checked with him, but I know Dr. Hilliard is still working at the National Herpes B Center, but it's academic.
And then we also have a question from Jennifer, who asked, is there a preference on wound cleaner, detergent, or antibacterial soap, or povidone iodine scrub?
So if you read the guidelines, they feel like maybe povidone iodine or chlorhexidine. But in reality, what has been shown from kind of dissecting the cases, soap and water is perfectly fine. And it just creates, unless you only use povidone iodine on your sink and it's always there and it's the only thing that's there, otherwise creates confusion if the researcher needs to think, okay, let me get the right whatever, I remember it's a different cleanser, what is it? So this is why our recommendation, and again, the guidelines say soap and water is also fine. They do prioritize chlorhexidine or povidone iodine, but it really doesn't matter. Whatever is, it's a process that you can train your staff on and that they can get to within 5 minutes.
And then our last question in the comments is from Marty, who said, for someone who has HPV exposure, is there concern for partner/spouse/household contacts until serology results are confirmed?
Yeah, that's a great point. So if you remember, to transmit, we need contact of the virus with the non-intact skin or mucous membranes. So unless the person develops vesicles, where then you get, remember the instance of the researcher that developed herpes B, had vesicles, and the wife who had eczema was applying hydrocortisone on the lesions, and she contracted it. So other than that, airborne ingestion is not common. So there's no precaution in the meantime, just symptom monitoring. And again, remember the chances, of course it depends, but at this day and age, and I hope we don't see another case, but we haven't seen another case in the US since we lost Beth. There were this report of these people, the 2 people in Japan, which we don't know when this happened because they don't say when it happened. And then we had an instance in China in the last few years where 2 macaque handlers who were doing autopsies on the macaques without proper PPE contracted and died. So I think in the last 20 plus years, everyone is much more diligent, and I hope we never see one. So just understand that the risk is extremely low. It would only be 0 if there was intact skin in touch with the secretions or materials. Anything other than that, it's hard to say that it's 0.
So we have a couple more questions that I think we might be able to get to. Frank asked, do you recommend a 6-week lab follow-up or just baseline and 3-week follow-up?
So if prophylaxis is given, the guidelines and Dr. Hillier suggests just 1 follow-up. So basically you have the initial exposure and you just check when you expect antibodies to start becoming positive around 3 weeks or so. And if that's negative, she usually recommends to stop there. If there was prophylaxis that was adequate within the time frame, and would stop there. But I would call her. It's not because not everything fits the box. So I would definitely check in with her.
Esther also asked, for mucosal membrane exposure, is first aid recommendation to irrigate with normal saline for 15 minutes, or if not immediately available, just tap water?
You're absolutely right. Saline or tap water is perfectly fine. 15 minutes, and again, quickly and within 15 minutes. You're absolutely right.
And then the last question that we have is from Jennifer again, and she asked, can you review the post-exposure lab monitoring and wound swab?
Yeah, so I didn't get into what happens So it's not recommended anymore to swab the laceration or the wound on the scientist. It's not recommended to do that anymore because it was found to have extremely low value. So for the exposed scientist, the only thing we need to do is serology. And actually, if you go to the National Herpes B website, you will see that it says that since, I can't remember, 2022 or something, we don't request wound swabs on exposed scientists. So this was great. See, one little progress there. Where they do request swabs, but usually it's not our responsibility. It's the veterinarian's responsibility. So if there is a scratch, a bite, anything that has to do with a macaque that's live and somebody who's handling and is around macaques, then the veterinarians have protocols on what they need to send for the macaque. So that's a separate discussion that happens between the veterinarian and the herpes B center, and those samples are pretty useful. But again, they take so long to come back. Usually, the person has already completed their 2 weeks of valacyclovir. Is that clear? Please ask follow-up questions if you need to. That's why, and I have a lot more slides with more specifics that I can share with you, but I wanted to be able to take questions. And as you know, I don't know everything.
Well, I think that's
But I want you guys, I want everyone to feel comfortable not knowing what to do. It's fine. It's perfectly fine, but that's why there is a protocol. So I think my take home is, when in doubt, just get that valacyclovir in quickly, and then kind of more details and outreach. And infectious diseases doctors, it's on our board. So herpes B is a topic on our board. So we know, we have to know how to manage it. So you can refer them to us, or you can page ID on call in your tertiary hospital. They'll know what to do about it.
perfect. I don't see any more questions, and thank you so much, Dr. Iliaki, for your time. I want to be cognizant of your clinic schedule this afternoon. But yeah, I think this was a phenomenal overview, and thank you all for joining us.
Thank you.